We are very excited about our presenter today on COVID and beyond delirium best practices. Donna Marie Fick is a distinguished professor at the Pennsylvania State University College of Nursing, Elouise Ross Eberly Professor of Nursing and Director of the Penn State Center for Geriatric Nursing Excellence. Dr. Fick received her BSN from Berea College, her MSN from the University of Cincinnati, and her PhD from the University of California, San Francisco. She is editor of the Journal of Gerontological Nursing, is nationally and internationally recognized as a leading expert in geriatrics, and is best known for her work on delirium superimposed on dementia. So I will now turn things over to Dr. Fick, and let's do a quick test audio with the group. Dr. Fick, can you say hello?
Yes, I should say probably good morning, good afternoon, and good evening, since I'm not sure where you're coming from.
Thank you. Can somebody just chat in and let me know that you can hear? Just a quick yes will do. Great. Okay, we have a yes. So Dr. Fick, you may get started.
Thank you. Thank you, Shannon, Donna, Lisa, and Comagine, and I'm thrilled to be here. First, I would like to tell you a quick story about Juanita. So Juanita, in my early years as a board-certified geriatric clinical nurse specialist in San Francisco, I worked with a chronic care management program. We were all advanced practice nurses, and we were seeing older adults across settings of care. So no matter where they went, we would follow them. And how I met Juanita was in her late 80s. She actually was, I think, 92 the last time I had cared for her, so it was over several years. But the first time that I met Juanita, she was on what's called a 5150 or a 72-hour hold because she had pulled the fire alarm in her building, a senior housing where she lived alone. And she was confused, and they admitted her as a psychiatric hold. And so that was one of the first times I met her, and I came out to see her after that. She was there just not for the full 72 hours, but for a brief time. And in this particular program, we worked very closely with the primary health providers. But what we found with Juanita, and again, we worked over many years with her, so we did lots of things like bringing in more care for her and helping her have access to more care and helping her with reminders for her medication. But what we found about that specific episode was that Juanita had a dementia, a very early dementia that had not been recognized and not been assessed. So that's one of the first things we did. But the other thing we found was that she had a delirium on top of her dementia. So we know dementia happens over years and months and more gradually, but delirium is sudden and reversible. So the other thing that we found out with Juanita was we found out a lot. We spent a lot of time getting to know her and to find out what mattered to her. And we found out on this particular day when she pulled the fire alarm, one of the things that really mattered to her was during the war, she had worked as a telephone operator, and she had still had connections with these women, and she would go out to lunch with them. But Juanita had arthritis. She had hearing loss. She actually was pretty healthy for someone in her 80s. Again, she had mild dementia, but she had moderate incontinence. So that particular day, she had been put on ditropan or oxybutynin, which is on the Beers risk of high-risk medications. The Beers criteria list, which is a list of medications to avoid if you're 65 or older. And she had said, well, it's really important for me not to be incontinent when I'm out with my friends. And so instead of taking her usual dose, she actually doubled that. And she became delirious, and she had delirium superimposed on dementia. So again, we worked with her over time to review her medications, find out what matters, and get her off some of these medications. I tell you this to say that even though we're talking about delirium in the time of COVID, is that a lot of what I talk about today will be in this framework. This is called the 4 M's framework of age-friendly care. I've been involved in this until about 2017, and I am on their advisory board. But this is the reliable implementation of the 4 M's with every older adult every time. And I have found, I love the 4 M's because I find that it fits very well with delirium. I like to say good delirium care is good care. So again, what matters, aligning care with what matters to the older adult, their goals, their preferences, and you can see how this played out with Juanita, what mattered to her, thinking about medication. So deep prescribing or avoiding high-risk medications. And again, this was a very big issue with Juanita because she was on a medication that was causing her to be even more confused on top of her dementia. And by the way, after we cleared up this delirium, she stayed at home for almost another 2 years before she went into a nursing home facility, where we also paid attention to what matters in medication and mentation and mobility. So I give you that context, and at the end, I think I have a slide if you want to know more about that. You can go to the Institute for Healthcare Improvement site. So what is delirium? Again, delirium is an acute, sudden, usually temporary confusion that's almost always reversible and preventable. And you'll hear me say this later, but prevention is a lot more effective than treatment in delirium. And a couple of caveats about this is to say that acute, means sudden. And so if you're thinking about a nursing home setting or a home care setting or a long-term care setting, acute can be minutes, it can be hours, it can be shift to shift, it can be days, but sometimes it can even be like 2 weeks. So the older adult that's not moving around as much, or that's sleeping a lot more, or not eating as well, or not engaging as much, many times that can be underlying hypoactive delirium, and then it comes to the point where they fall or they get more acutely ill. These are what we call the 4 features of delirium: acute, fluctuating, inattention. Inattention is really the hallmark of delirium. Disorganized thinking and altered level of consciousness. To be delirious on the CAM tool, which is one of the most reliable and sensitive tools, though it can be difficult for clinicians to do at the bedside. So I'll tell you about another tool that you can use that is based on the CAM. So to have delirium with the CAM, you have to have features 1 and 2. So it has to be acute, you have to have inattention, and you can have either disorganized thinking or altered level of consciousness. And again, remember what I said, that altered level of consciousness can be someone that's just not moving slower or sleeping a lot in their chair and not moving around. It's not always that person that's yelling out or pulling things out or taking their clothes off. The other thing to know about delirium is that it's really costly. Again, studies have shown that it costs as much as $164 billion a year, as much as congestive heart disease and diabetes. And the other thing, it has very poor outcomes. We've done several studies where we found that mortality was increasing these individuals, 25% mortality at 1 and 3 months, functional decline, increased cognitive decline. So again, even if they have dementia, many older adults in long-term care, many residents in long-term care may have a baseline dementia. It's still critically important to treat the delirium, because what happens if you don't and they have repeated delirium is it increases that trajectory of cognitive decline. We also find that individuals with delirium have distress. So even those with dementia said they were fearful, they were afraid, and they remembered this experience. We also know that delirium is one of the #1 reasons for falls. And actually, when you prevent delirium, when you look at a meta-analysis of studies that prevented delirium, and 2 of those studies, the meta-analysis that I believe I give you the reference for at the end, in 2 of those studies, when you put in a delirium prevention program, you're able to decrease falls by 64%. Again, good delirium care is good care, and we'll talk about that. The other thing I want to say, because it's timely, is that delirium is the epidemic within the pandemic of COVID-19. This is an editorial in the New York Times by Sharon Inouye, who's one of the world's experts on delirium. She's a geriatrician and one of my colleagues on our studies. And a couple of things that she writes about this that are most important. One is the impact of the no visitor rule, and we'll talk more about that. But the other is that we're seeing a lot of delirium in COVID-19. Many older adults that present with delirium and have delirium throughout and have delirium afterwards. And the other is, this is not the time to throw out best practices for delirium. It's the time to really double down and know what the best practices are. Again, this is a study in Brazil where they found that 33% of those with COVID had delirium, and delirium was a predictor of death, length of stay, and ventilation support. And I always have this caveat of when you're talking about COVID-19 data, that a lot of this is preliminary, right? Because we don't have randomized control trials. But this is one study I present to you. There are several that show that delirium is important during COVID-19. The delirium is so important that this is a slide that I've had probably for 20 years since or 30 years actually, since the late 1980s, where I ask people to think about delirium in older adults. And this is very relevant in long-term care, acute care, and in home care, so across settings of care. So all these conditions that you see here, pneumonia, congestive heart failure, COVID-19, infection, depression, dehydration, they may not present in the typical way in older adults. Many times their only presentation is something's not right. They're, the daughter's saying, this is just not my mom. She's just different. There's a change. So again, many times the only presentation of these conditions was delirium. We also find that in COVID-19, they may not mount a temperature, they may not have a cough, they may not have shortness of breath. The same thing in pneumonia and some of these other conditions. So again, think delirium and assess for delirium. The other thing I'll say is that delirium in COVID-19 is a perfect example of this. Over my career as a geriatric specialist, over 30 years, I've many times have seen that delirium is a medical emergency. It's not always a medical emergency. Sometimes it's, again, like I said, it's more subtle, but I have many examples of when it was a medical emergency. So it's always important to be thinking delirium first. So don't label someone as having dementia or another condition. First, make sure that you're rolling out delirium. If you do assess delirium, again, there are many tools. And so if you already have a tool that you're using at your facility, that's great. But what I'm going to say is many of the, I think the MDS perhaps has the CAM. And what I'd say about the CAM is if you're not doing another cognitive assessment tool with the CAM, then it's probably not accurate. So I'd ask you to consider and look at these tools. And again, this is one we developed, so I have some biases. But this tool has 93 to 96% sensitivity to pick up delirium when delirium's really there. The other nice thing about this tool is we have free videos, we have free trading cards, but we have a study that we just completed with over 900 assessments where we have nursing assistants doing this tool. And the nursing assistants love doing this tool because they're so close to the residents already. And there are 2 questions. Now, there are directions because you have to do it exactly how it is. It has to be 12 months of the year, and again, look at the instructions. But those 2 questions are, please tell me the day of the week, and please tell me the months of the year backwards, saying December is your first month. And if they get stuck, you can prompt them, but if they get any wrong, of course, I always let them finish, but if they get any wrong, that's positive for delirium. One thing about this tool is it's very good about picking up delirium when it's there, but sometimes it has false positives. So if they pass, that's great. You have a baseline, you can document their strengths. But if they don't, you would go on to do another tool called the UBCAM. And again, I don't have a lot of time to talk about the UBCAM, but the card, which I give you a link to, will walk you right through it. The UBCAM is usually not done by the nursing assistant. It's done by a registered nurse or a physician. And the UBCAM can be done in about a minute because you've already done the UB2. So you can skip some of those questions. And this is an algorithm that walks you through the UBCAM. The UBCAM is great because it has very high sensitivity, but it also has very high specificity. So you probably have heard these terms a lot because of COVID-19 testing, but it's really a very good tool because you don't have a lot of false positive or false negatives. I also wanted to go back and show you this one. These are just quotes from the nursing assistants about the screeners. But again, we have over 900 assessments, and we collected qualitative data from nursing assistants who say, I really like doing this, and they can do it well. In our pilot studies, nursing assistants had 100% accuracy in using this tool, so they can be trained quickly and they can do it well. So what do you do if someone has delirium? First of all, if you're going to assess, let's say you say, oh, we're going to use the UBCAM or the UB2 in everybody in our facility, you want to make sure that if you are screening for delirium, that you have a plan in place before that to prevent delirium and to make sure you're doing the best practices for delirium. Because if not, you can do more harm. And I am so passionate about delirium and the care of persons with dementia. I have an adult son with Down syndrome. He has a 50% chance of getting dementia when he's older. And I want these individuals to have the best care. And the best care in most cases is a non-drug person-centered care approach. So if you're going to screen, make sure you have best practices in place. Prevention may seem simple, but again, the literature, this particular review, and I give you the citation for it, showed that in 11 out of the 14 studies, they were able to prevent delirium. And in 2 of them, they decreased falls by 64%. So things like orientation, cognitive stimulation, so regular visits from family and friends, stimulated family presence. So things like having an iPhone with a 1-minute video from family or someone that's familiar and comforting to them. Making sure that they have their favorite fluids to drink, or that they have a marked hydration thing that they can see. The other really big one that may seem simple is sensory and vision, making sure glasses are clean and hearing aids are in. Infection prevention, pain management, hypoxia control. And then probably my favorite, because we know it helps both dementia and delirium, is mobility. Mobility. Every older adult, I believe, every older adult in every setting, again, starting with what matters, should have some kind of daily mobility goal or daily physical activity goal, because we know this will help them if they already have dementia, and it will, if they don't, it will help prevent both dementia and delirium. And the data, again, is not perfect, but the data is pretty strong on that. If, let's say they do get, let's say they have COVID-19 and they do get delirium, these are some of the approaches for best practices. The first thing is to remove or treat the underlying cause, which I'll talk about in a minute. We know that, again, COVID-19 causes that, but there are many other things. Oftentimes with delirium, it might be multi-causal. So it might be a new medication plus they're dehydrated, or they have dementia and they're in an unfamiliar place, or they're suddenly very isolated, or they're malnourished, or they have an underlying infection. So first you treat the cause. You try to remediate complications. So some of the main complications of delirium are because we don't use best practices, because we medicate them, and that makes the delirium worse. There is no FDA-approved drug for delirium, and there's a paper I'll show you in a minute that just came out that looked at lots of data and said we should not use medications for delirium prevention or treatment. So if your facility is doing that, I would tell you that I don't think that's best practices, and you should look at the literature. And then the other is thinking about restoring cognitive and physical function, because oftentimes when they're delirious, they're losing function. And some of the big complications of delirium are falls, aspiration pneumonia, pressure ulcers. So thinking about that. And then the other is managing and understanding delirium behaviors with a non-drug approach. All behavior has meaning. I'll say that 20 times a day. All behavior has meaning. My behavior has meaning. People that are on this call, your behavior has meaning. All of us, you really see that during the pandemic. All behavior has meaning. And it's the same thing with delirium. So trying to figure out, like, are they doing this because they're misinterpreting stimuli, because they're in pain, because they can't communicate that they have to go to the bathroom, or that they're scared because they know something's wrong with the delirium. So trying to understand those behaviors and not cover them up with drugs. Again, these are the most common causes to consider for delirium, but it is not an exhaustive list. Usually, as a geriatric specialist, the 3 I've seen that are sort of low-hanging fruit are often dehydration, which happens more in the summer, but it can also happen in the winter, because older adults in general are not as thirsty. So if you're not encouraging them to drink, they can easily get dehydrated. Medications, especially anticholinergic medications that are centrally anticholinergic, can impact the brain. are very common. Benzodiazepines, antidepressants, sedative hypnotics, and pain medications. Again, just a few. This is the article. I'm not going to talk about it, but just tell you that there's very strong evidence that we should not be giving antipsychotics for delirium. If we do deprescribe medications, the other thing I'd say is we have to offer something else. We have to offer it for both the staff who are dealing with behaviors or issues. I was on a call the other day with Dementia Action Alliance where they reminded me not to use that word disruptive behaviors. We should call them behavioral expressions. Again, they're trying to communicate what's going on. But for instance, if you take them off a sedative hypnotic, you need to help them sleep. This is a great website, deprescribing.org, and they have links to the Empower patient brochures. And you actually help the older adult think about how the medication might be causing them problems, and then other things that they could do to help go to sleep besides the medication. This is another site that I love. It's called Nursing Home Toolkit, and it looks at specific behaviors that they're having. So maybe wandering or going in other people's rooms or disruptive vocalizations. And it helps staff walk through alternatives to what you might do to help with that behavior besides medications. This is, again, I told you I spoke with Dementia Action Alliance, and these were some of their concerns that come directly from people with dementia in times of COVID-19. And I think it's very important, again, to bring their voice. Needing to be hospitalized and not having someone with them, being isolated because of the visitor policies, not having the equipment to participate in online like all of us do today, suddenly not having their programs or activities that they used to, and of course the tremendous impact of their change in routine and being socially isolated. I also want to say that if you're older adults in your facility or transferred to the hospital, they have the right to have a support person at the bedside. This is very clear. The Americans with the Office of Civil Rights settled several cases. They have made this very clear, that supporters are essential for persons with dementia and for many older adults who might be aging with disabilities to help them communicate, make decisions, feel safe, understand choices, help them with safety issues and personal cares. So be ready to tell the health system why you need a support person, and also how your support person will be safe. And you know, I saw a article the other day about how many providers in long-term care and hospitals have lost their lives, and particularly in long-term care. These people are heroes. So it's critical to keep them safe, but I think we can do this safely. This is an experience that they had in a Dutch nursing home. And again, they were able to, they have a table in here that talks about how to do it safely. And their experience has been allowing visitation did not increase COVID-19 cases. The other thing I'll say, and many on this call may know this, but the CMS Commission on Nursing Home, and there's also another commission through the National Academy of Medicine, but they address this issue of visitation. And I know they're looking carefully, at least from looking at those recommendations, it looks like they're looking carefully at that and how we can help. And I wouldn't call them visitors, I would call them essential support persons get at the bedside again of our older adults, particularly with dementia and disabilities. This is one of the things I've done during COVID-19 is I've had many people reach out to me, sometimes young people with autism or Down syndrome or other disabilities, but many older adults who had loved ones with dementia that they couldn't visit. And I thought this was a beautiful example of a colleague of mine. She said I could share that, but she was able to see her dad. He had dementia and he got much worse. He relied on her for communication and all kinds of things. And she made this for him, and it went from place to place. So again, I know that you're pretty good about this in long-term care, but this will help you if they're in long-term care, making something up like this that's current about what kind of things they can do if you're not able to be at the bedside. Again, really helping them know the older adult and know what kind of things will help them care for them better. We also have one about adapting the 4 M's for staying home and staying healthy. And some of these things are different, like getting 90 days worth of a refill, reviewing your medications, keeping a routine, staying active, but again, within the context of the 4 M's. These are some hyperlinks for my resources today, and I hope that you'll check them out. And please reach out to me personally if I can help with any other resources or citations. This was the article I talked about prevention, another one about deprescribing. Again, resources for the Beers criteria, which are medications to avoid an older adult. And they also have handouts for laypersons. If you want to join the age-friendly movement, here's how. And then here's some information from Comagine. Thanks for listening today. Oh, and here's my Twitter and my email.
Thank you so much, Dr. Fick. We have a few minutes for questions, and while you are all thinking of questions, I just wanted to briefly tell you about our new Comagine Health initiative. We're starting a partnership to reimagine healthcare, working with providers across all care settings to improve resident and patient safety, infection prevention, addressing behaviors and opioid misuse, and working to reduce admissions, readmissions, and emergency room visits. So providers will receive a range of support, including expert coaching and technical assistance, education and resources, and access to their performance reports. And this is all free. There's no cost to providers, and joining is as easy as putting your name into chat if you're not sure if your group has already come on board. So we'd love to work with you. All right, so give folks a couple of seconds to think on questions. We did have one question, I think, that got posed to the group, but maybe Dr. Fick, we can have you share anything creative you've been hearing. There's a question on how are you promoting mobility for residents and patients during a challenging health crisis like COVID-19? And just wondering if you've heard of anything creative in your work.
Yeah, I think that's a great question. I'm getting some feedback, but that's a great question. And, you know, I think thinking about mobility creatively. So if they can't, let's say that they're isolated in their room or quarantined in their room or their house and they can't get out, is, you know, things like chair exercises. So, you know, putting your arms over like this and seeing how many times you can go up and down. Things as simple as that are really important. And the important piece about it is doing it every day. The other thing is that they do have access to Zoom. I know, again, I'll give example of my son, who is an adult with Down syndrome and intellectual disabilities, is that, you know, he has the literacy of like not even the first grade, yet he can write Zoom numbers down. So again, even persons with dementia, I think, can interact on some things with Zoom. So anyway, they have they have dance parties and they have exercise clubs over Zoom. So even having the family having like an activity or an exercise 15 or 20 minutes. Again, the importance is really that daily mobility and also making a connection to how they're going to feel better. Because, you know, none of us will do exercise unless it's fun, unless we're going to feel better. So I think it's better if you can get outside, because then you have the double fresh air and nature, which by the way has evidence that it's also good for older adults. But again, trying to be creative and knowing that mobility doesn't always have to be, you know, running a 5K or even walking, that it can be other things that chair exercises and things that may not require being outside. But that's a great question. I'd love to hear if others have ideas.
Wonderful. I'm seeing kind of a quiet chat room at the moment, so I'll give you another few seconds if there's any questions that you have for Dr. Fick while we have her. And while we're, again, just allowing for you to think on anything that you'd like to ask, I put in our chat our posted Hot Topics webinars there, and a link to where you can access our 2020 webinars. And we also have ones dating back to 2019 and 2018 as well. We encourage you to take a look at those, and you can use them for in-service training and staff education. So.
I think we're all, but I wonder if others could chat in, or any of you, do any of you have a delirium prevention program, or are you assessing delirium, or are you part of the age-friendly movement? I just wondered.
So go ahead. Yeah, you can go ahead and chat if you have a program and want to share any information on that, or we're aware of some of the groups that Dr. Fick was mentioning.
Maybe while we're waiting for them to chat in, this is Donna. Dr. Fick, could you tell us how they might be able to initiate an age-friendly program in their building? What's a simple first step for them to get this started?
Yeah, so go to the Institute for Healthcare Improvement website. First of all, it's free. That's the important thing. It's free. And so go to their website, and then they have these action communities. That's kind of similar to what you're doing, is they educate people about the 4Ms. The thing is, most of you are probably already doing a lot of these things. And to get age-friendly status, there's 2 levels, level 1 and 2. Get level 1, I'd like to say, is pretty easy, because it's really just a commitment to saying this is how you're going to work towards measuring these. So I bet everybody on this call could at least get level 1, and they're putting a lot of effort to supporting all settings. So in Pennsylvania, we work with a large federally qualified healthcare center. So it's a clinic, and we have age-friendly status. We also work with hospitals. We also work with nursing homes, assisted living, CLCs. So again, oh good, you're chatting in the link. So again, level 1's fairly easy. Level 2 does you do have to submit a little bit of data, but again, it's pretty easy. Like, you can even do small quality improvements and say, hey, this is how we're assessing and acting on the 4Ms. I will say that one thing with age-friendly care is you can't just say, oh, we have a mobility program. The point of this model and the evidence base for this model is that you go after all 4Ms. And the other thing I'd say is they tell you exactly how to do it. They have a ton of resources. So they don't just say, go do this. They give you manuals. If you're already using something for mentation or mobility, that's fine. But if you're not, they will help you figure out how to assess and how to act on that M. So it's a very, I know I'm biased, and I am on the on one of their faculty, but again, it's free. The goal is to have 50% of all healthcare systems be age-friendly by 2023. And I think that's 2,500 systems, and I think we're close to 1,000 already. So please think about joining us.
Wow, that's very exciting to hear. I put a link to the Institute for Healthcare Improvement in chat, and we would be glad to follow up with sending out information. They have twice a week huddles and lots of great information. Their huddles are about 20 minutes, which is really, again, great for folks who are having, have such busy schedules as you all do. Lori had asked, how do you join? Is that through the IHI site, Dr. Fick? Oh, okay. So Dr. Fick said that she could send the manual for age-friendly care and how to join.
So the action communities, one just started through the American Hospital Association. It just started, but you can actually still join that one, even though we had our kickoff. And that's through the American Hospital Association, but it's the same program. It's just they're helping out IHI. So they call them action communities, kind of like you guys, just trying to help be supportive as people try to improve their care. But I will send you the manual and the links and stuff so that if people want to join.
Wonderful. Okay, so I want to respect the fact that I know you all are busy and have to get back to your day. So I would like to take this opportunity to thank our presenter, Dr. Fick, once again for a wonderful presentation, and thank all of you for joining us and for your efforts to keep residents safe and well cared for during this challenging time. Please go ahead and there's a little poll asking about your satisfaction with our event today. So please go ahead and take a moment to answer that. And we will be actually doing a special edition of our Hot Topics in October. I believe we're looking at October 23rd, looking at COVID and the flu and immunization. So a pretty hot topic right now in the healthcare world, and we hope you can join us then. So on behalf of Comagine Health, again, I'd like to thank Dr. Fick. This was great. And thank all of you for everything that you do to keep residents safe and well cared for. And thank you for coming today. This concludes our Hot Topic session, and have a wonderful weekend.